So this is obviously a pretty salient topic for many of us as cutaneous oncologists. Just as background, again, we all know the treatment algorithm for high-risk resectable melanoma has really significantly evolved in the last few years. We're commonly counseling our patients on the pros and cons of using adjuvant therapy, whether that be PD-1-based monotherapy or BRAF-directed therapy. And we now know patients with macroscopic stage 3 disease or resectable stage 4, perioperative approaches with a PD-1 backbone are now recommended. But with these changing algorithms, we really do have many questions and challenges that are coming up. First, in the adjuvant space, we really lack the ability to determine on an individualized manner who really needs systemic therapy. With these evolving options certainly comes challenges. First, in the perioperative space, we really lack the ability to determine on an individualized manner who needs systemic therapy. And in the perioperative space, though we're certainly learning a lot about how we can use pathologic response data as a surrogate marker, we still need to identify those patients who we might need to escalate therapy in, as well as those who we might be able to safely de-escalate our therapies in. And image-based surveillance, though a standard, is certainly riddled with a lot of problems. We get false positives, and we also know we're not able to truly detect macroscopic or microscopic disease, I should say. So additional tools are needed, and this is really where we wanted to explore the potential role for ctDNA in this space. So for the specific study, this was a single institution study for which we partnered with Natera, and we used their unique tumor-informed Signatera assay. So for those who might not be familiar with this assay, first the tumor is sequenced using whole exome sequencing. We are able to identify a unique set of patient-specific somatic single nucleotide variants, and using this data, a custom designed multiplex PCR NGS assay is performed for each patient. And it targets up to 16 of the highest ranked tumor variants that was found. Thereafter, this custom assay is used to identify ctDNA in serial blood samples. So in our study, we looked at both an adjuvant cohort as well as a perioperative cohort. And to be eligible, patients needed to have tumor tissue available for sequencing and then certainly available to undergo serial blood draws. In the adjuvant cohort, pre-specified blood draws included at the time of surgery, 6 weeks post-operatively, and then every 12 weeks thereafter for at least 1 year. And we attempted to time the blood draws with scans. And this was regardless of the adjuvant strategy that was prescribed by their provider. As the ICI indications expanded, we then enrolled a perioperative cohort as well. The adjuvant strategy was identical, but in addition to those post-operative blood draws, we also had blood draws at the time of each cycle of pembrolizumab or ipilimumab nivolumab administration, as well as at the time of surgery.